And good afternoon, everyone, and welcome to the Center for Practice Excellence Speakers Series for April the 7th. My name is Zubin Austin, and I am the Academic Director of the Center. It's my pleasure to welcome you today to our session. I'm going to turn it over to our Program Manager, Annalise Mathers, to introduce our speakers and to moderate our discussion. I'd really like to thank Anne and Wade for spending time with us today and sharing their work and their thoughts on this work, as well as to all of you for also joining us today. Over to you, Annalise.
Wonderful. Thank you so much, Zubin. And I'll echo your comments in welcoming Anne and Wade, who are joining us together today. Great. Anne is actually across the hallway from me here at U of T. So finally nice to have a bit more in-person interaction. And Wade is close but far out in BC. So thrilled to have them both with us here today for our first CP speaker series of the year. Actually, we've been doing quite a few events with the Open Summit, which has been taking place lately in March, and then we'll resume in May, which is a large gathering of researchers focused more broadly on medication management. But thanks, and great to see everyone joining us today to get us kicked off for 2022. Just before we get started and I introduce Anne, I would just like to acknowledge that I am on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and that this land continues to be home to diverse First Nations, Inuit, and Métis people. I invite the audience from wherever you might be today to also consider a land acknowledgement from your area in what might be appropriate. So today's event is focused on a topic we haven't explored too much at CPE, which is randomized control trials on interventions to improve the use of medications in older adults, achievements, challenges, and lessons learned. And we are very, very fortunate to have Anne Spinewine joining us today, all the way from Belgium, although like I said, she's actually sitting across the hall from me right now. Anne is a clinical pharmacist and professor in clinical pharmacy in Belgium. She works part-time as a professor at the Université Catholique de Louvain in Brussels and part-time as the head of the clinical pharmacy service at an affiliated teaching hospital. She teaches pharmacotherapy and evidence-based medicine, and she also leads the hospital pharmacy residency program, as well as a CPD program for community pharmacists. Her research focuses on the evaluation of the quality of use of medications in clinical practice and the effect of several approaches for improvement, with a specific interest around appropriate prescribing in older adults. She's currently a visiting professor at the Ottawa Hospital Research Institute in the team of Jeremy Grimshaw. And just before I hand it over to Anne to get us started, she has mentioned that she's more than delighted to meet up and set up conversations with anyone who might be joining us in the audience today. I think, Anne, you can speak more to that, but I think has a very deep interest in fostering collaborative relationships with people internationally, and can take some of those collaborations back home to Brussels and also back in Ottawa. So Anne, I'll allow you to provide contact information, etc., if people would like to follow up with you after your presentation today, but I will turn it over to you now to get going.
Thank you, Annalise, and thank you for this introduction. I'm very delighted to be here today and to share my experience about randomized control trials on interventions to improve the use of medications in older adults. Let me just move this from my screen. Okay. Yeah, so a little bit of my background to get started so that you can understand where the RCT experience comes from as well. So I was graduated as a pharmacist. We don't have a pharmacy program in Belgium. So this is a master in pharmacy program more than 20 years ago right now. And at that time, I was very interested in clinical pharmacy, but there was no opportunity to practice clinical pharmacy or even to get trained into clinical pharmacy in Belgium at that time. And so I decided to go for 1 year in London, where I took an MSc in clinical pharmacy, international practice and policy. And this is really where I learned about clinical pharmacy, pharmacotherapy, etc. And so when I finished that program, I went back to Belgium and I wanted to practice clinical pharmacy, but again, there was no opportunity to do that. And so the course director in London, Soraya Dillon, told me, well, you know, Anne, I think there's only one way for you to do it. You should do a PhD, prove the added value that clinical pharmacy could have in Belgium, and then maybe that will open doors for clinical pharmacy practice and education. And so this is exactly what I did. I did my PhD thesis in clinical pharmacy. I was the first to do one in Belgium at that time. And as you can see here, I spent some time in Canada at the very beginning of my thesis with Louise Mallet, where I was trained about clinical pharmacy on acute geriatric in Montreal. Then after my PhD, I was lucky to be able to combine academic position with clinical pharmacy position in a hospital. And as Annalise said, I'm now a visiting professor with the team of Jeremy Grimshaw. And the idea behind this is that I really wanted to build up my skills in implementation science. So basically my work in Belgium, as Annalise said, is divided between work at the hospital, where I lead the clinical pharmacy team, very different practice from what you have in Canada, very different in terms of resources. We don't have as many pharmacists as you have here. And also the scope of practice is a bit different. I do teach pharmacy students, and I'm also involved in CPD for community pharmacists, which I like very much. And then about 30% of my time is about research, and this is really what we are going to talk about for today. And so for today, our story, I will tell you the story of 3 randomized controlled trials I was involved in. From the first trial that I did during my PhD thesis to 2 other trials. The first one is the monocentric trials, and the other 2 are multicentric trials. They all aim to evaluate the effect of complex interventions to optimize medication use in older adults. But as you will see, those trials were quite different one from another. So the first trial is the trial that I did during my PhD. So trying to prove the value of clinical pharmacy practice in Belgium. And so that was really the starting point. And before starting the trial, we did some preliminary work, I would say, trying to understand really what was going on in acute geriatric wards. And so we did a qualitative study to understand the reasons for inappropriate medication use at that time, where we interviewed physicians, nurses, but also elderly patients. And so this really helped us to design the intervention that was mainly based on the pharmaceutical care model that you know, and that was existing at that time in the UK, in Canada, and in the US, but that was totally new to Belgium. And so what we did is that we did a randomized controlled trial where we included a bit more than 200 frail older patients admitted on 1 acute geriatric unit at a teaching hospital. So this is only a monocentric trial. The intervention was so pharmaceutical care on the ward, so that included medication reconciliation on admission and at discharge, a medication review during hospital stay, participating to the ward round and the multidisciplinary round as well, and providing written and oral information to patients at the time of discharge. The control group was usual acute geriatric care, so randomization was made at the level of the patients. And our primary outcome measure was about improvement in the quality of the prescription from admission to discharge using the medication appropriateness index. And as you can see here with the odds ratio, there was a significant, statistically significant and clinically significant improvement from admission to discharge in the intervention group as compared to the control group. We also saw a trend towards decreased mortality and visits to the emergency department, but of course the study was not powered to find a significant difference on those outcomes. So this is a trial with very, very limited resources at that time. I made it almost not fully on my own, but I didn't have much support except from some statistical support and some support to do the follow-up course with the patients as well. So this is also why this trial has some weaknesses and there's some risk of bias that we were not able to control for, but still the impact of that trial was, in my opinion, quite strong. Once we released the results, we had a very strong interest from pharmacists, from physicians, from hospital managers, and from policymakers. The day after I presented the data, the chief medical officer at the hospital I did the trial offered me a permanent position to launch clinical pharmacy in his hospital. And also, this trial, together with other pilot experiences that were going on in Belgium at that time, contributed to the launch of a national call for clinical pharmacy pilot projects. And so there was some money available to start clinical pharmacy project in about half of the acute care hospital in Belgium. And so that was really a very important start to then really get clinical pharmacy started at the Belgian level afterwards. So that was the first trial. The second trial is very different. So it's called the COMMON study. COMMON stands for Collaborative Approach to Optimize Medication Use for Older People in Nursing Homes. So that was performed in the long-term care setting. And the story of that trial is that, so this trial was funded by INAMI. INAMI is the national insurance system in place for healthcare in Belgium. And so they had decided to give a certain amount of money, a bit more than 2 million. So that was quite important to fund pilot projects around multidisciplinary work around medication use in nursing homes. That wasn't meant to be a randomized control trial at all. They wanted to provide money for nursing homes and some money for a research team to launch pilot projects and to evaluate. It was a kind of quality improvement approach to evaluate the effect of multidisciplinary work in that setting. What we managed to do is that because we had quite a relatively large number of nursing homes who wanted to participate in this pilot project, we were able to negotiate with INAMI that we wanted to go for a randomized control trial design, because what they wanted at first is that they wanted this pilot project to occur in between 20 and 25 nursing homes. Because we had more than 50 nursing homes willing to participate, we said, well, we are going to transform these into a randomized control trial, so we will have a stronger design and a lower risk of bias to evaluate the effect of this approach. And so this is how we ended up doing that trial. The objective was really to assess the impact of a complex intervention on the appropriateness of prescribing in that specific setting. So randomization was made at the nursing home level. You see here, that's the map of Belgium, the different nursing homes that participated into the trial. And we included 1,804 nursing home residents under the care of a participating GP, and that was something very highly challenging to have enough participating GPs and also nursing home residents. But we managed to do it, and it was a very, very, very interesting experience. So the healthcare professionals who participated in the trial were general practitioners, of course, what is called a coordinating physician. So that is a general practitioner that is responsible for bringing some coordination around medication use and other stuff at the level of the nursing home. We had nurses on board and also the pharmacist who was responsible for delivering medicines for nursing home residents. Pharmacists don't have, I would say, any other pharmaceutical care scope of practice in nursing homes, at least they didn't have at that time. And so it was really new for them to be really involved as a member of those multidisciplinary boards in this trial. The complex intervention was developed based on data from the literature and also on a series of consultations we had with the different stakeholders. And so it mainly involved three main components. We first offered blended training in the form of an e-learning for the different healthcare professionals, and also some on-site training to have medication review practiced on different clinical cases. Then there was some what we called local consultation. Basically, that means we asked nursing home to spend twice 2 hours, more or less, to discuss on specific classes of medication to try to reach an agreement on how these medications should be used at the level of the nursing home. And then the main component was interdisciplinary case conferences, where we asked people that for each nursing home resident included in the intervention group, we would ask those people to sit all together around the same table and spend probably 20 minutes or so reviewing the medication of each resident. And we asked them to do that between 2 and 3 times over the course of the study. The study lasted 15 months. So this was something very exciting for us in terms of developing and implementing the intervention. Very challenging also because of the nursing home setting. I think it's probably more challenging than in the acute care setting, but very inspiring. Our primary outcome measure was again measurement of improvement in appropriateness of prescribing from baseline to the end of the study. And as you can see here, we found significant improvement in the intervention group as compared to the control group. We had secondary outcome measures, including clinical outcome measures. We didn't have patient-reported outcome measures. We didn't find any positive or negative significant differences between groups, but in this prescription measure, I would say we had an impact of the intervention. What was the impact of that study? Well, less than I would have expected, at least so far. So what we did is that after the study, based on the different results that we had, we made final recommendations to the funder. And we did that using a Delphi process with different groups of stakeholders. So we made a long series of recommendations, some requiring some money and others not. And it is very frustrating to see that overall no major decisions have been taken in the months that follow the trial. So this is certainly one frustration for us. Probably, well, the study is still frequently quoted in Belgium, and it plays a role in different discussions that are going on to fund medication review by pharmacists at the moment, but still it was very surprising for us to see that INAMI had provided more than 2 million euros to fund this trial, and afterwards decided more or less nothing, or at least nothing that we wanted to see decided. But anyway, I think we don't want to be too negative about that, because I think at the level of pharmacists and other healthcare professionals, this study definitely had an impact on how they want to practice, how possible it is to move the practice forward and be involved into more patient care and multidisciplinary discussions with GPs and nurses as well. And also from an educational point of view, for example, the e-learning that we developed for that study has been used by hundreds of students in pharmacy afterwards, and also by many other nursing homes. And so there has been some impact in that way, but not at the level of the policy decision making. And finally, the third trial is called the UPRAM trial. So this is a trial funded by the European Union. Again, focusing on multimorbid older adults, 70 plus in this trial. Basically, the background was that there was limited evidence about what is the effect of structural pharmacotherapy optimization on clinical outcomes in that population. And so we designed a cluster RCT again in 4 different EU countries. So Belgium, Switzerland, the Netherlands, and Ireland. For which we included a bit more than 2,000 patients. The randomization occurred at the cluster level, was the physician level. And basically the intervention was a structured medication review approach that included the use of a clinical decision support system called STRIPA that uses stop-start criteria, but also other aspects such as drug-drug interactions. And so basically the output of the CDSS was evaluated by a team made of a research physician and pharmacist that prioritized the recommendations to give to the hospital physician. Then potential modifications in the treatment were discussed with the patient and family, and the written medication review plan was sent to the GP. The control group was usual care, which was to some extent different across countries. The primary outcome was drug-related hospital admission at 1 year, and we didn't find a statistically significant difference between the two groups in that regard, as you can see here with the hazard ratio and the confidence interval. There wasn't either a significant difference with regard to the first preventable DRA, drug-related admission, and we had no differences in other secondary outcome measures, except for one difference in quality of life at 12 months. We did several subgroup analyses, again, no difference except for a difference across sites. What we saw is that there was a significant effect in favor of the intervention at the Louvain site, which was the Belgian site, but not in the other sites. That's only a subgroup analysis. It's very frustrating for us in Louvain to see that result, but we don't know if it's a result, if it's a chance finding or if it's really a difference in the effect of the intervention. We can make some assumptions, but we don't have enough data to really be able to have quantitative data to understand that difference. Anyway, in the paper, we brought up some potential explanations. I just want to highlight two that are really, again, for myself, some lessons learned from that trial. The first one relates to the design of the intervention. Is it really realistic to think that a single time point pharmacotherapy optimization that occurs in the acute care setting can have a positive effect over a 1-year follow-up in relation to drug-related admission? Probably we were too optimistic, I think. Also, there was some limited collaboration with general practitioners in the intervention, and also shared decision-making with patients was lower than what was expected. My second message here is that there might have been some mismatch between the intervention and the primary outcome measure, because what we see is that most of the recommendations that were made to modify the prescriptions often involve drugs that are not the most likely to lead to drug-related admission. And so again, maybe the trial wasn't sufficiently powered or designed to try to find a significant difference in that regard. So now that I've told you the story of those 3 trials, what I would like to do in the next slide is just to touch upon 6 different topics that relate to achievements, challenges, and lessons learned. And the first one might be very obvious to you, but I think it's still very important to mention. Teamwork in those trials is key to success. If I compare my first trial, where we had very limited resources and limited teamwork, to the EU trial, there's a big difference. And I think that's something very important to consider. Having in the co-research team clinicians, trialists, statisticians, implementation scientists, and health economists, and so on is very important. Having a very strong clinical trial unit is also important. We don't have such a strong unit or center at my hospital, but in the EU trial, this was taken over by the clinical trial center in Bern, highly experienced in running trials, and I also believe that this makes a difference in the success of the trial. That's not necessarily related to the success with regard to the primary outcome measure. Of course, you need different other categories of persons that I list here, but I just wanted to quickly highlight that this teamwork is very important to me. My second topic is about timeline and preparation of the trial. When you know that you are going to do a trial, some people already want to jump into the first day where you recruit a patient. And so this recruitment and follow-up stage is so important, of course. But what I want to highlight here is that preparing the trial is as important as recruiting patients. And so if I take the experience of this EU trial, so that was a 5-year project. It took us 18 months to have this preparation stage ready. And I think that's really the minimum. Then 2 to 2.5 years for recruitment and follow-up, and then the rest for data analysis and dissemination. So when I refer to preparing the trial, I refer to 2 different things. First of all, developing the intervention. We just don't want to say, this looks like a good intervention to test at the moment. We really want to build up an intervention that is likely to succeed. And so in my first trial, basically, we adapted the pharmaceutical care model that had been developed in the US, in Canada, in the UK to the Belgian context. That wasn't too complex. But for example, in the common trial in nursing homes, we really built a new intervention, not from scratch, but from the literature and from consultation with different groups of stakeholders. There has been over the last few years more and more recommendations on how to build interventions. I just want to refer to one recent publication on that. This is the guided checklist that provides, I think, useful recommendations on what you need to be careful about when you develop an intervention. That goes from engaging stakeholders to considering using theory to develop your intervention. And the second step is about feasibility testing. I think that's something very important because too often we develop intervention and then we directly jump into the main trial with the risk that you end up having very low implementation rates. And to some extent, we did some feasibility testing in Common and in OPRAM, probably not as much as what I would like to do for the future trial. But again, this enables you to fine tune your intervention and to make sure it is well adapted, acceptable to the different people connected to the intervention. And so to me, you need to at least have, if possible, a few months to do that feasibility testing. The second aspect of getting the trial ready is about designing the trial. And so that's when you have to answer hundreds of questions about eligibility criteria, outcome measures, etc. And of course, we want our trials to be as pragmatic as possible. I think we were successful in some aspects. In OPRAM, for example, the eligibility criteria were relatively broad. We didn't have too many exclusion criteria, but we were not so successful in this pragmatic aspect with regard to delivering the intervention. For example, in OPRAM, delivering the intervention required to have a research physician and pharmacist on board, requiring to have someone entering the data into the CDSS system because it was not embedded in the electronic healthcare record of the patient, etc. So it was quite resource intensive, which is not the best, but that's the way we were able to do it. But again, if you want your trial to be fully pragmatic, that also influences the choice of the intervention. My next topic is about choosing adequate outcome measures, and that's probably one of the most difficult part of the trial design, I think, because this has definitely an impact on your end results. And so selecting outcomes to define whether the intervention works or not is a difficult question. What do you want to measure and how can you measure it? And so I think that one of the first questions, if we want to build up a new trial, is trying to look at, is there a core outcome set available? So a core outcome set is a set of the minimum outcomes that you should measure when you do a trial in a specific topic. So core outcome sets were first developed in the field of rheumatology, but now you can find core outcome sets in many different areas. And so the COMET website can help you to identify if there is a core outcome set in your field of research. And that's still, I think, very underused core outcome set, but I think it's a good way to start looking at whether a core outcome set exists. With regard to the choice of the primary outcome measure, and so the work of calculating the right sample size for a trial, I think it's difficult but necessary to find the right balance. So you want your difference to be clinically relevant, but you also want it to be realistic. And sometimes we want clinical relevance and we aim for something that is not fully realistic to achieve. And so again, having statisticians sitting together with clinicians and if possible with patient representatives really helps to try to find the right balance with regard to this aspect. And finally, if there is access to automated health administrative data. And if those data are relevant to the topic we are working on, of course, that's great to use such data. It wasn't possible in any of the 3 trials I presented today, so we didn't use such data, but I would love being able to use such a data. I think that you have probably an easier access than we have currently in Belgium to such data. But again, that's something we were not able to do in our previous trials. I just want here to highlight some work that we did with regard to outcome measures in OPERM. So our group was really leading a specific work package on outcome measures. And I want to highlight 3 different things that we did in that regard. So first of all, during the first year of the project, we developed a core outcome set for clinical trials around medication review in multimorbid older patients with polypharmacy. So we did some systematic review, qualitative work, and then a Delphi process to come up with a list of 7 validated outcomes that should always be measured when we do a trial of medication review in that population. And of course, in the OPERM trial, we included all these outcomes in our primary or secondary outcome measures. So that was a very interesting work in which we involved also a relatively large number of elderly patients, and that was something very interesting. Secondly, our primary outcome measure was drug-related hospital admission. We didn't have a fully validated measure available for that, so we developed a standardized chart review method to identify those DRAs in older people. And finally, because drug-drug interactions was one of the outcomes that came out of this core outcome set, later on we validated with different experts a consensus list of potentially clinically significant drug-drug interactions in older people. So this is work that comes before the trial or at the same time of the trial, and that can help to do the appropriate measurements for the trial. So those primary and secondary outcome measures I showed you before can help us to evaluate whether the intervention works. I feel it is essential in those complex intervention studies to plan to look from the beginning below the tip of the iceberg between being that primary or secondary outcome measures I mentioned before. And so we really want to move from this to how, why, for whom, and under what conditions the intervention work or doesn't work. This is very helpful to then better interpret the results of the trial. And so having a process evaluation protocol ready from the start, I think, is something very important. And this is something we did for the common study. So we had from the beginning planned to do a relatively detailed process evaluation, for example, to look at what has really been implemented. We want people to do 3 medication reviews for nursing home residents, but do they really do them? What are the facilitators' barriers to the implementation, and in which context the intervention is effective? And so we did a mixed method approach using qualitative data with focus groups and quantitative data mainly related to fidelity to the different components of the intervention. And I really feel that this helped us to understand a lot better the effect of the intervention, but also the barriers related to the intervention. And that was very helpful when we then had to draft the recommendations for the policymakers. And so that's, in that study, I really feel that we were able to open this black box of this complex intervention and to understand the different components and how people reacted to them, and how should it be similar or different in the future if we disseminate those these intervention further. We didn't do so well in the OPERM trial. That is my personal view on it, but we still had some bits of pieces of process evaluation, if I can say it that way. And one example here is that I share here is that we did some evaluation of the patient's perspective of the intervention and of the medication review in the hospital setting. That's a very busy slide, but basically what we mainly did is that we did semi-structured interviewed with almost 50 people, which is a relatively large sample for a qualitative study. So from 4 different countries with 4 different languages, which makes it even more challenging. But this really enabled us to identify what was the patient's experience and what were the barriers towards medication optimization that we wanted to achieve. And 2 of those barriers, for example, were that we didn't reach shared decision making at the level we wanted to in that intervention. And also we had too limited communication with the general practitioner. And so again, that kind of additional data from the trial really helps us to better understand what happened and also helps us to better plan for future trials. My 5th topic is about the case of negative trials. There have been a few negative trials around medication review and around deprescribing in older people in recent years. And that's what your face looks like when you are one of the researchers of the team, when you see for the first time the results presented by the statistician. And that was my face when I saw the results from the Operam trial, of course, with the amount of energy and time you've spent in those trials. When you see that there's no statistically significant difference, you are not so happy. But I think that negative is really a misnomer. And I'm fully convinced that there's so much to learn from those trials, and they all tell very different stories. A negative trial can be negative because of a power issue, because the primary outcome was not sensitive enough to the intervention, because you had implementation issues, or because at first your intervention did not adequately address the problem. And I feel it's so interesting to look and to deep into those negative trials to try to understand what happened. And I just want to share with you, you're probably aware of that very nice Canadian study that was released a few months ago. So the MedSafer study that happened to be negative with regard to the primary outcome measure. So that was adverse drug reaction 30 days later, if I remember well. But still, they found such a big difference with regard to the level of deprescribing in the control and intervention group that, to me, this is still a very positive trial that is very interesting to share with other people. So I think that changing our minds about negative trials is something very important. And my last point is, after the trial ends, because you have spent time and effort to collect different kind of trial data, there are a lot of opportunities to use those trial data after the end of the trial. We didn't do that with my first trial, and I think it is a regret, but we did it with the Common and the Operam trial. I just want to share 2 examples with you. The first one is from the Common study. Later on, we decided to have 1 PhD student working on benzo deprescribing in the nursing home setting. And so we went back to the trial, to the Common trial data, and this really helped us to see what's the current situation with regard to benzo prescribing in the nursing home setting, and did Common what was this Common intervention associated with more deprescribing. So that was the first part of a PhD, and then it helped us to build a new study specifically designed towards benzo deprescribing. And my second example uses the data from the Operam trial. I mentioned to you before that we developed a new way to identifying drug-related admissions. And so looking back at those data, we were able to evaluate the performance of our tool that includes the use of triggers to measure the positive predictive value of the trigger tool we had been using, and using those data, making suggestions for a version 2 of the trigger tool that we expect will be more efficient and also more usable at the clinician level. So I want to finish with some view of what our future randomized control trials would be. Clearly, the idea is that we want to maximize efficiency, use, and impact of our research. And we want to do that by leveraging implementation science. And that's also one of the reasons I spent this year in the team of Jeremy Grimshaw. So basically, I share here 3 main methods papers that are key sources of inspiration for us for our future trials. And as you can see with the list of authors, several of them work in Ontario. So Canada and the UK are important sources of inspiration for us. And basically what we want to do is really to have a more structured work towards developing intervention. And so what we are currently planning to do or doing also already in the nursing home setting is that we first identify barriers and enablers towards benzodiazepine using the theoretical domains framework. This then helps us to selecting behavior change techniques and define the intervention. We will go through a detailed feasibility trial stage to measure feasibility of the trial design and feasibility of the intervention. And if that proves positive enough, then we will move to a main cluster randomized controlled trial. And so we have plans, and we just received we were just successful with 2 large grants, including a new EU grant that will be called the Be Safe project, that will enable us to do 3 trials, one in the hospital setting, one in the community setting, and one in the long-term care setting about benzodiazepine. Also, what we want to do better, or what we want to develop further as compared to the trials we've done before, is stakeholder engagement, including patient engagement towards the research process. And also part of the work that we plan to do will include developing and refinement of program theories to better understand what works in what context with whom. So we've really learned lessons from our previous trial so that now we want to do that. And we are recruiting 4 PhD students and 2 postdoctoral students. So if you go on our website or on my Twitter, you will find some information on that. So I would like to conclude by saying that I'm fully convinced that randomized controlled trial, also together with other sources of evidence, including evidence from observational studies, generate significant knowledge on how to better use medications in older people. I'm deeply convinced that those are significant opportunities for us as pharmacists to advance pharmacy practice and research, both locally and internationally. For example, when we started the EU OPRAM trial, so we had a team from Switzerland where clinical pharmacy practice was not part of usual care really. And so the way that we work together has really, I think, made it progress in that Swiss partner as well, so to advance pharmacy practice. Yet those trials are challenging to conduct. They require teamwork, rigor, and experience, and further maximizing impact and efficiency is possible. And that's really, we hope that we are going to be able to do in the next trial that we will start soon. And so as Annalise said, I'm really happy to discuss this further with you if you are interested after this presentation or later on. So thank you for listening.
Wonderful. Thank you so much, Anne. And feel free to put your contact information in the chat box as well if you'd like. I know there's probably quite a few people online who know you and are connected, but I think that would be great, especially if your team is recruiting. Speaking of teammates and people you know, I'm going to introduce our discussant for today, which is Wade Thompson, and then we'll open it up for audience Q&A. So Wade is an assistant professor at the University of British Columbia. He's also a pharmacist and researcher working to ensure older persons are taking medications that are necessary, effective, safe, and consistent with their healthcare goals and treatment preferences. This primarily involves developing and evaluating strategies to stop medications when they're no longer a good fit. Wade approaches deprescribing and polypharmacy management research with a multi-methods approach, incorporating qualitative methods, pharmacoepidemiological methods, knowledge translation, and implementation science. He's also an investigator with the deprescribing.org initiative. Wade, I'll pass it over to you for your remarks. Thank you so much for joining us.
Thank you. And I'll just start off by thanking you, Anne, and just expressing my gratitude that there are researchers like you that are conducting these large scale randomized controlled trials, which are answering a lot of important questions in the field. And it's really a huge service to the field to have such rigorous studies like the ones you've conducted. And I would definitely echo that. I don't see anything negative about some of the recent trials which have come out in the field, because it's definitely giving a lot of food for thought and a lot of useful information about how to advance the field and move forward. But certainly the results of some of the recent trials which have come out, like OpeRAM and like MedSafer, which you spoke of, I think they've made a lot of people in the field kind of stop and really think critically about some of the approaches that we have been taking so far. And so I just want to share briefly some of my own reflections and then just discuss some things with you. I have a lot of questions, but I'll first share some thoughts. So in seeing trials like OpeRAM and MedSafer, I started by thinking about where we have come from in the field of medication optimization and deprescribing, and some of the earliest work was in identifying barriers to medication optimization and barriers to deprescribing. And some of the earliest barriers were from healthcare providers, that there's a lack of tools, decision support tools and guidance and education about things like deprescribing. And that, if there were more tools, that it would be easier and less time consuming to deprescribe in routine practice. And then there were also some barriers from patients around fear of consequences of stopping medications and limited awareness about medications, which sometimes hinders engagement. So those were well described. But then there are these other barriers, health system barriers and cultural barriers, which are some of the things you spoke of in your process evaluation, those things at the bottom of the iceberg, which are coming to light more. And I think like your process evaluations have been great because they're shedding light on those things, but difficulty with care coordination, difficulty communicating between healthcare providers, and how those things are really important for durable and practical interventions in this area. And then that cultural barrier where we still very much have a culture of prescribing, and prescribers feel pressure to follow disease-specific guidelines, which are focused on starting drugs and intensifying treatment and chasing numbers. And so people tend to end up on a lot of medications, and that culture is hard to combat. And so those are things I think that sometimes are difficult to address. And the reason I'm bringing this up, or the reason I thought about this, is because the approaches that have come out in some of these recent clinical trials in the field, they make sense. Like OpeRAM, if you give prescribers and healthcare providers a tool to use in practice, that's what they want, right? That's what's supposed to be a barrier to deprescribing. So giving them a tool should, make them more confident and should improve health outcomes. But we found that hasn't necessarily been as impactful as we might think. And then there's another trial which came out recently called the Optimized trial, which we've been writing about on Twitter and thinking a lot about. And so that got at this question of, okay, if we engage patients, we give them information about deprescribing before they have a visit with the primary care provider, we give healthcare providers education about deprescribing, provide them with education tools and communication tools, then maybe that will increase deprescribing in practice. But that Optimized trial similarly found no difference in medication use for an intervention arm compared to a control arm, and no difference in clinical outcomes. And that blew my mind, because I'm like, that is what we've been saying all along. We need to engage patients and empower them, but we found that didn't really end up doing much. So again, maybe it did actually do something, and I'd be interested to hear your thoughts on the Optimized trial. But again, I'm thinking now about some of those other barriers, like the health system barriers and the cultural barriers and the environment in which deprescribing takes place. And I wonder whether you think that some of the interventions which have been developed and tested so far are adequately addressing those environmental factors, the culture and the health system barriers, because my perception is that they haven't really tapped into that. And I realize that these are issues that are larger than deprescribing, like how to facilitate care coordination and make communication better between specialists and GPs and pharmacists and GPs and pharmacists and specialists. And these things are probably hard to change, but maybe if we can address some of these health system factors, that might make things like tools and education and patient engagement more effective. And then in terms of other health system approaches, things like reimbursement for prescribers to de-prescribe and address polypharmacy as more of an organizational factor has been something that's been brought up, and just organizational support and prioritization of things like de-prescribing may result in structural change that might make it more, again, durable and practical in the real world. And then in terms of changing the culture, I think that there's starting to be some work on that, but if there's some way to integrate de-prescribing guidelines into treatment guidelines, whether that can lead to culture change so that prescribers and providers are feeling a lot of pressure to follow guidelines, but if the guidelines include de-prescribing recommendations, then that could go a long way towards, saying that, we're following the guidelines. Guidelines are saying de-prescribe, and then that might, again, be a way to have tools and education and things like that be more effective. So those are my reflections as an observer of some of the recent evidence which has come out. I'm not saying anything new, I don't think, but just trying to think about where we might be going. So yeah, my question to you is, do you think that, future interventions should be addressing some of these other barriers, or whether existing interventions have really done that?
Well, I fully agree with your point. I think it hasn't been addressed at all, or in a very minor way. Those health system related barriers or cultural related barriers, and then it's not even measured. I mean, it's not easy to measure, but in none of the trials I have done, and in most of the trials there is that kind of thing is included, and this is something we plan to do for the future trial, certainly, and to have some experts at system level evaluations as well, to try to better understand how the system affects the intervention, and how the system is affected also by the intervention. So I think that by conducting more detailed case studies in addition to the randomized controlled trial, that can certainly help. But also we can consider having measurements, and this is, I think, ongoing in several trials. For example, if we take the example of the theoretical domains framework, we could measure at the start of the trial at the level of the physicians, and later on during the trial, to try to better understand if it works or if it doesn't. What are the mechanisms that make the trial work or not? Is it because the knowledge hasn't changed, or is it because self-efficacy hasn't been modified at the level we wanted? And so those are not system levels, I realize, but healthcare professional related barriers that we are not taking into account enough in the trials. For example, if I take the example of Operam, again, if we compare how we did the intervention in Belgium versus in Switzerland, I know, because I was involved in that the way the intervention was implemented was very different. And you don't have this information in the paper because we didn't measure and we didn't capture that correctly. While if we had done a detailed case studies or ethnographic study in addition to the trial data, we would have been better able to understand what worked or what didn't in the trial. So I fully agree with you that we need to go more towards better measurement of system level aspects and professional level aspects as well.
Because I just think of, like, when the trial ends and you want to take this intervention and implement it, in other environments, or scale it up, like what needs to be in place to make that happen, and whether, because you need to have more than, I think, just some of the intervention, like a tool or an education, and seems like there needs to be other things in place. I don't know if a trial can get at that. But I'm just thinking about, again, to drive practice change, ultimately, it maybe needs to be more than just what's in an intervention.
Yeah, sure.
But I mean, yeah, anyways, I'm just an observer, and I don't have the answer to this, because these are big questions that, as to Lisa's point in the comment, it's not a small thing. This is like, this applies to other areas than just prescribing and polypharmacy management. We're talking about, like, overhauling some health system approaches to care, which have been in place for a long time. So anyways, thanks again, Anne, and I'll yield to the audience.
Yeah, thank you so much, Wade, for those comments. And I think for asking the big and small questions, they're all important. I'll quickly flip it over to some audience questions that have come in. Tijal, thank you for an insightful presentation and discussion on the approach for RCTs for pharmacy practice. In the OPREM study, did you assess any differences between the arms' time to first hospital admission? Additionally, did you assess differences in between the sites for the intervention arm in their hospitalization rates post hoc to see if you can identify factors that impact hospitalization rates?
So time to first hospital admission was, sorry, maybe this one was not clear in the way I presented it. That was a primary outcome measure, time to first drug-related hospital admission. I don't know if the question is about hospital admission, but hospital admission was part of the secondary outcome measures, and there wasn't any difference either.
I'm going to interrupt. Sorry, Anne. I was just asking, I may have misunderstood. Was it just hospitalization rates or the time to the first hospitalization?
Yeah, it was the time to the first drug-related admission.
Oh, and there was no difference between those two?
No.
Okay.
Correct.
And the second question you kind of answered, because you said the intervention in Switzerland was different from the intervention in Belgium. And that's the key here, is fidelity to the intervention, right?
Yeah, but it's not fully in the way of fidelity to the intervention, because we have some figures showing that there are some differences, but not differences that can really explain the difference that we see in the outcome measure. But for example, so I refer to the fact that we had a research physician and pharmacist proceeding the CDSS recommendations and passing them over to the physician, to the prescribing physician. For example, in Switzerland, that was done by a senior geriatrician team member with a clinical pharmacist, while in Switzerland it was done by junior officer rotating every 2 or 4 weeks, which I believe is very different in terms of really the behavioral approach that you can have with such different teams. So we are not able to quantify, but this is the kind of difference in the way the intervention was implemented that could maybe make a difference in the effect that you get. That's what I wanted to say.
That's what I was getting at, because you had an international trial with a bunch of variables you probably couldn't control, even though it was randomized. But thank you. That was my only comment. Thank you.
You're welcome.
Thanks, that's fantastic. And I'll just get to a question from James Bowen in the comment box as well. Excellent presentation, Anne, and thanks for your reflections on pragmatic trial design. For stakeholder engagement, have you considered having a policymaker, a member of your clinical study team, and/or patient partners as study team members as well?
Yeah, so if I go back to the common trial, so that was a trial in nursing homes. We had a stakeholder engagement group that we meet very regularly when we design the trial and during the trial as well. And those included policymakers. So that was policymakers, healthcare professionals, but no patient representatives. That bit was missing. And in this trial, at some point, also nursing home residents were not involved in the intervention, which is a weakness. But we decided not to involve them because already having the pharmacist, the nurse, and the GP around the same table was already something very challenging for the context we were in. Bringing a nursing home resident in addition to that, we felt this was too much. But so we had a stakeholder engagement group with policymakers, healthcare professionals, researchers, but no patient representative. But in the BeSafe trial, so that's the new EU trial we are about to start in next September, we have I answer yes to both questions. So we will have a patient advisory council set up during the first months of the project. So this is again a 5-year project. And this patient advisory council with members from we have 6 different EU countries for that trial, will be involved in all different aspects of the projects. And so that will be something very new as compared to what we did before. And I really look forward to that experience with the Patient Advisory Council. And we will also have policymakers engaged because in one of the work packages, we will look at clinical pathways in the 6 different countries and system level aspects with regard to benzodiazepine prescribing. And so we will have some interviews and focus group discussion with policymakers as well. So this is something we are trying to do better, I would say, in the future trial, and we have foreseen engagement of those people.
Fantastic, thanks, Anne. I think very important. That's definitely been a conversation that has been happening very frequently here with some of the CPE conversations about the importance of working with regulators and policymakers, and of course, patient partners in all aspects of the study design. So I think we'll look forward to hopefully seeing those results at some point in the next 5 years or so. Mm-hmm. We are at the end of our time for today. So I think on behalf of the CPE, I would like to thank Anne and Wade. Anne, thank you so much for joining us. I think this is a very exciting time for you, hopefully, in getting to sample some of the research across Canada in some ways. And thank you, Wade, also from joining us from the West Coast to provide your remarks and hopefully providing a bit more of an opportunity for you two to collaborate. In other CPE news, we will resume our regular programming in May and June, and then we'll also be holding the next 2 events for the Open Summit in May as well. So stay tuned for that. But until then, wishing you all the best, Anne, in your remaining time in Toronto and Ottawa. And thank you everyone for joining today.